appreciate the introduction. I appreciate IlluminOss for helping us out with taking care of these patients, and to you all attending, and of course to Amr, who I've known for quite a while now, and I'm really happy to do this presentation with him. You know, my heart, of course, is in fracture care and problem fractures, and so anytime there's an opportunity to kind of investigate things and try things that offer some benefits, I'm interested in them. And so, you know, I kind of came into the IlluminOss stuff with that kind of an approach. And we're seeing increasingly challenging fractures, and distal femur is just but one area that can be challenging. And so hopefully what Amr and I are going to do tonight is show you some cases in and around the distal femur that show some utilization as an option, you know, for some of these challenging fractures. And so the first thing I'd like to talk about is the acute periprosthetic distal femur fracture. You know, these are, I mean, they're all over the place now. They come in frequently. They all have the same kinds of problems, and we certainly haven't solved it with isolated lateral locked plating, or for that matter, medullary nailing, even if it's an option in some of these prostheses. But I'll go through this case with the 76-year-old male, pretty typical age, ground level fault, pretty typical mechanism. He's got a left total knee. He weighs almost 300 pounds, and he's got a closed convoluted left supracondylar distal femur above his left total knee. Like many patients, a lot of associated medical comorbidities. And this particular fellow, he's also had a gastric bypass surgery, which, you know, brings into some question about, even though he's a big fella, some of his nutritional content. And so risk factors for him, for me, for isolated lock plate failure is his BMI, and above that is absolute weight, his renal disease, which may complicate his bone healing, and of course his bone quality, you know, particularly in the metaphyseal and the retroprosthesis area. And so a pretty typical look. He's got some medial sided comminution. He's got a total knee. He's got, you know, a small distal segment. And so, you know, our options get to be a little bit limited other than isolated lateral lock plating. You can use two plates. You can use some sort of medullary support if it's available to you. And so I thought he had good indications for the IlluminOss. And for me, I've just kind of put down some bullet points here that I think are important for me to go through. And a lot of this is, you know, you still have to respect and go through your principles of how you're going to do this, and sequencing this is important, I think, as we'll find over the course of the next 45 minutes or so. You know, so for me, I do a lot of these reductions indirectly with the application of an external fixator, and it's a little different than just the spanning frame. I still use the spanning frame, but now I have total control racing if I kind of put Shannon pins directly into the distal condylar segment and attach it to my external fixator bars, because now I can control the distal segment, both recurvatum, varus valgus, etc. And once I obtain that, then I can go ahead and do my provisional plating that you can see here, which it can also indirectly help with some of the translational deformity, and can also help indirectly with some of the alignment deformity, and working with the external fixer, you can get that reduction. So here now is, you know, I've got my provisional plate on. I've taken a lot of care to make sure that I don't have any kind of fixation intruding into the medullary canal where the IlluminOss device is ultimately going to go. And so this patient has a prosthesis that doesn't allow me to get into the traditional start point for, say, a retrograde nail. So I'm going to do a medial start point. And I think here on these images, you know, you can see that I've just got a small incision, percutaneous. You can't see the incision, but you can see the guide wire going up the medial column, both in the AP and lateral views. And so I've used a medial start point because of the closed box. And through this, I'm able to plan the length of the IlluminOss device, how high up I want it to go, how not to interfere with some of my other fixation points. And it allows me to ream the canal so that I can put in a symmetrically sized column of the IlluminOss device. And so here I've just, through that same reamed hole, I'm able to insert the balloon. I can judge the length of how high I want it to go. I don't think I need a lot of stability up in the isthmic portion, so I don't need to go higher than that. So that allows me to put in a bicortical screw up top and help with some of my stability, because down lower I'm going to be using unicortical screws, and screws in the epiphysis that are out of the way of where the IlluminOss is going to go. And then, of course, you can see here we've already started to inflate the device to give us a nice column of acrylic within the balloon that not only acts as a physical stabilizer, just by virtue of its presence within the medullary canal, certainly within the presence of the medial column, but allows me, which I think is what really drew me to it, to put in stabilization into it and kind of create this substantially much more stable construct than with an isolated lateral plate before. And I would always struggle, with the plate nail constructs that I always felt like I was kind of compromising one fixation device for the other. And so that neither of them had the absolute kind of ideal fixation utilization. And so this is in part why I really started to get interested in the IlluminOss for these particular fracture patterns, is that I could fix into it with optimal located locking screws, whether you use the term nominal or in their ideal location for locking, and as well as giving me that physical presence of being within the canal. So here's just the final screw placement and construct for that bigger fella that I think really is going to help his stability, because I think all of this still comes down to how stable can we get these components. And you can imagine that this fellow is going to have a lot of stress on his fracture from even just normal movement in and out of a chair, back and forth into the bed, let alone walking.
Dave, have you had any problems with the medial start point, kind of making that curve around the metatarsal area or the distal metaphysis?
I have had some problems with that, and actually, it was the very first case that I did that, and that was a distal femoral non-union in another really big patient, and it had to do with being able to get by an intramedullary malunited fragment of bone. And so that was the one that I think is the only one that I've had where I can say significant challenges of not being able to make that turn. And I think if I was to do that case again now, I would get it. I think that was I just needed to be a little bit more aggressive with working on that particular area, and I would have gotten that. But I think that's been it. So far, I haven't had any troubles starting low and not being heroic with the positioning of that, and really just running it right from the low medial side up into where the anatomic axis would be, and starting my reamer and then passing the curveball tip guide rod and just being careful when I ream. But so far, it's been okay. How about you?
So I've had a little bit of a challenge, but I think the reason for this, I think my angles were too sharp and too steep.
Yeah.
Too transverse of a starting point, essentially, and not so. But yeah, I mean, but I see the value in the medial start point to kind of reestablish that medial column.
Yeah.
And kind of really build off of that.
I think that one of the challenges is making sure that you're staying true to that start point and that you're not just reaming or destroying the bone, inadvertently proximal to where your start point is, or else you can really start to erode that bone if you do, some not paying attention to your reamer passing, or you're starting to use reamers that are really kind of getting a little bit too large. But so far it's been good. I make a small incision there to make sure that I place it right. I spend time getting the start point, just like any other nail, just spend time getting a good start point, good trajectory, and then be careful as you ream. And I really try to, the IlluminOss will inflate differentially, and so what I mean by that is there's some areas that can be smaller than other areas in terms of their diameter. So, I'm always kind of cognizant of being able to retrieve one of these, and so I try to, if I put in a 12 reamer, I put in a 13 reamer, the distal femur in somebody like this can accommodate a heck of a lot more than that. And the balloon can potentially inflate a lot more than what you've reamed, especially if the bone is really vacuous there. So I do try to be cognizant of that and not overinflate, because I always want to retrieve it,
Yeah.
But so far the medial start point has worked out pretty well. I kind of prefer to go, you know, in the traditional area if the total knee replacement will accommodate that. Once again, I think it's just more traditional. I think it's conceptually simpler. I think retrieval is probably better. But once again, you just always got to be careful that you can access it, and then it's not in some crazy curve or some sort of funny alignment that makes it more difficult to get it out if you ever need to get it out.
And then like this case, which is, I mean, it's phenomenal, the reduction on it and holding it is, you're really having your reduction done and you're just putting the IlluminOss in as an augmented device at that point, right? You're not really using it as a reduction aid in some manner.
No, I think the reduction has to be done. I think that this is where kind of a little bit of planning is critical, you know, of just imagining how you're going to sequence these. And, you know, I'm still, as we'll maybe see in the next case, you know, a believer of, you know, compression for non-unions and axial compression. And you got to take a minute to kind of say, well, how the heck am I going to sequence this and make sure that I have enough fixation, but yet that I'm not having things in the way of the canal, because when the balloon goes up, it really can't be too disturbed or else it'll potentially tear while you're inflating it, and still respect those principles of getting your reduction and doing those kinds of things. Because I think once the IlluminOss is in there, it's real hard. Not that I've tried it, but I think it's real hard to fine tune any reductions because the stability you get out of it is already pretty significant, you know, once you inflate one of these guys.
Yeah. Yeah.
Maybe we'll see that in the next one. Yeah, so here's a distal femoral non-union. So, you know, here's another guy. He's almost 80 years old, 215 pounds. He's got what I would call a hypertrophic distal femoral non-union. He's got a failing lateral fixed angle plate. Yeah, I just imagine distally, he's probably got some, at least at a minimum, age-wise, poor femoral bone quality. He's 18 months. He's got a bunch of medical problems. Once again, the diabetes and chronic kidney disease. So my treatment goals for him, of course, got to be restoration of alignment and maximize stability. And so, you know, I still believe compression plating is a great way to go. But I've had some of these older folks with these particular injury patterns, you know, fail just isolated compression plating for their just femoral non-unions. And here you can see the guy standing, you know, he's bending through his screws, you know, he's deforming his weight bearing compared to his non-weight bearing alignment. You can see how he's changing just with weight bearing. Send him over to X-ray and have him stand on it, take the same kind of film. And I think you can see, you know, he's kind of got this empty zone in the metaphyseal area where he's been augering out his metaphyseal bone. So, you know, I want this guy to heal. I need him to be stable. I need him to be able to start weight bearing without this deformation, because that hurts. And it's obviously, you know, compromising his union. So, you know, principles, mobilize and realign him, you know. And so for him, he's kind of got a stiff non-union. So I've just put an osteotome across him to mobilize it. And then through that, I'm able to just manually realign his fracture to a reasonable point and hold him with some really quite stout pins. And I've tried to keep those pins out of the way of where a medullary implant would go. So here I've got a retrograde start point just with traditional opening reamer. And then I've applied my plate, and you can see that my plate's already been kind of pre-bent, and I'm trying to take care of making sure he doesn't have the golf club deformity. And I've inserted some screws into the distal segment, and then I can put on my ATD once I get some acceptably secure fixation distally, and I can give him the axial compression that I think is really helpful for this particular pattern. And then once I do that, then once again, I've already prepared my distal portal, if I can use that term, and I can go ahead and insert the balloon. I finished off my reaming, insert the balloon. Everything is nice and stable and static right now. You know, the plate's on. I've got some unicortical screws. I've still got the ATD on, so it's holding things. I may have a clamp on there. I've got out of the way screws in the distal segment. I can inflate the IlluminOss now. Nothing in the canal, so no problems with that. And then once once it hardens, now I can take advantage of all the rest of the screws and actually drill through stuff that feels good, that gives me stability. And I've basically created a loaded, compressed disfemoral non-union like we're supposed to, and then really augment it with the stability that the IlluminOss helps out with. So it takes a little bit extra kind of planning, but I think that that's what you got to kind of do if you want to take full advantage of this and have things work. So this is just a way of sequencing it to make sure that everything is lined up right. But it does take a moment or two to sit there and say, okay, well, how am I going to do that? And then sequentially go through each step and say, yep, that's how it's going to go. And then it works out pretty smooth.
Just kind of philosophically, like how do you envision IlluminOss? Because I've kind of battled this idea in comparison to some of this nail plate combination stuff that we're seeing now for the distal femur.
Yeah, I think that's great. First of all, I'm not a big fan of medial and lateral plates, and I think that that's a real good option. And I'm not sure why. Maybe I just kind of grew up a little bit seeing dual plates just for distal femurs just be a bit of a mess, frankly. And so I like that. And I think if you've got somebody with a thigh that's really massive, I still don't want to go over to the medial side. And frankly, sometimes, you've got a guy with a calcified artery and I got to get above all this kind of stuff. And it just seems like an extensive kind of set of dissections. But mechanically, it's very, very good. But in the absence of that, then I'm looking at, doing something medullary, and whether I use a strut allograft kind of idea, or I use a retrograde or even an antegrade nail. I think that those are great. The problem I have with like strut allografts is by the time I get them to fit, I wonder how much structural support they have or they offer. And then I feel like I'm drilling the hell out of them, and then they're weakened even more. And you can say, well, you did the same thing with the IlluminOss, but like when I start whittling on a fibula, basically the only thing I'm putting up there seems to be like the medullary part of the fibula, if I can get it to fit.
Yeah.
So this I thought was an intriguing option to me, and I after a few goes at it, I really felt like this helped me, because I typically get a little bit frustrated with the plate nail constructs, even though I've done a lot of those. I think that that's a great way to go. I think that having something drillable that I can anchor into while still giving me that medullary support has been, helpful for these particular geriatric, revision, non-union stuff where I really got concerns about bone stability or bone quality to give me stability. I think those other techniques are really good, but
with it, were you letting your distal femur patients weight bear right away?
No, I'm a real conservative guy still with weight bearing, and I know what the articles say, and I understand all that. I'm very comfortable saying that I'm a conservative guy when it comes to weight bearing. But this patient population, I really like to do something that I can get them at least weight bearing something on without risking it all going to heck, and just all falling apart. So, that's why I think this is a much more comfortable letting somebody weight bear if they can, that's geriatric with this. I think plate nails, I do the same kinds of things, but I do get a little apprehensive when it's just an off-axis implant like a lateral plate or something like that. Even if it's locked, I think that, as you see, they some of them can struggle in poor quality bone.
Yeah.
So to your point here, the acute, here's this guy. Okay, so of all the people that you want to at least be able to get him out of bed and get into a chair and get him upright, and maybe help himself with the nursing staff and all that, is this fellow. He's 93 years old. He's got an interprosthetic distal femur fracture. Oh yeah, he's medically, kind of like what a 93-year-old man is, with a heart block and all that kind of stuff. So to me, this guy's got poor proximal and distal bone segment quality. And I think this guy's really, it's very important for him to have some degree of early or immediate weight bearing, or else he'll never weight bear again, potentially, or maybe even say probably. So I thought he was another really good indication. The indication here for me was not just bone quality, but what I wanted him to do post-operatively. So if I was going to do this, my goal has to be immediate weight bearing,
Yeah.
or at least allow him to be immediately weight bearing. So same kind of idea here. I've kind of used an X fix for my indirect reduction, length alignment, and rotation. He's got a couple pins on the right hand side in his tibia, a couple pins in his femur just below his total hip, and then through that I can kind of fine tune the reduction with manipulation of my external fixator and get it kind of closer. And then I can apply the plate just for some additional stability. And once again, I'm going to fix this without any obstruction of the medullary canal. And I can go ahead and get my start point. I can, take advantage of, okay, I'm going to end there, so I can use a bicortical screw there. I'm going to bridge his total hip stem, so hopefully we don't get that, tip of plate, tip of implant kind of stress zone or stress area. Keep the fixation posterior in his distal femoral area. And there, I think on the right-hand side, you can see the balloon in the distal femur that's skinny, it's deflated at that point. And then go ahead and inflate it, and then go ahead and put in the rest of your fixation through the IlluminOss and through the rest of his distal femur like that. So, this guy, post-operatively, he can stand to transfer. It's not like I expect this fella to just go like walking down the hallway. I don't expect that at all. A lot of people just hurt. We tell them they can weight bear on their femurs, after nailing it, but they hurt. And so I think that this is good though for him to be able to get upright, and hopefully he's stable enough that the people that I've done these kinds of things, and whether it's with plate nails or with ATDs and the non-unions, they immediately feel solid. They use words like solid, stable, stuff like that. They really, I think they feel that, and especially if they've had a bit of a wobbly fixation before, they can appreciate the stability that you get. So, those are just some examples.
These injuries are, I mean, like all of like the product, distal femur, periprosthetics are challenged, but these interprosthetics, particularly with these long stem femoral components, I mean, that diaphyseal, metatarsal bone is just atrocious. It's just not satisfying at all. And certainly, my experience has been, I'm with you. Like, I'm pretty conservative on weight bearing, and I get made fun of by people. I'm like, well, I mean, I had the couple of weight bearing early, and like it looked like a hardware shop gone bad, like in a couple of weeks. And I'm like, yeah, I'm not doing that again. Like, that's not going to happen. So I'm not a big early weight bearer. But I will say, like, for me, with kind of similar to the nail plate combinations with IlluminOss, I feel a little bit more comfortable letting them go a little bit more.
Yeah, totally. I learned that when I was a fellow from Chip, and we were using pretty flexible IM nails. It was the old Synthia AO Universal, and so a very thin-walled nail. So I kind of grew up with real flexible nails that you kind of had to really watch them a little bit with their weight bearing. But and no doubt the modern day nails now are, not even modern day, but nails for the last 25 years have been able to do that and weight bearing. But you'll see some failures every now and then, and so this makes me feel better. I'm still very conservative, but I do feel that this population is the ones that you have to do something about it.
I've done nail plate combinations, but I hate them. I despise those days, because it's nothing, just like you were highlighting earlier, like it's, dancing around the nail, for plate, or, putting the interlocks in for the nail, like none of it's optimal. Like, if I did it individually, I guess the way for me, it's like if I was doing a nail alone, I wouldn't really be that happy with the fixation I got with a nail plate combo. If I was doing a plate alone, I wouldn't be that happy. So I'm kind of in this middle ground. And then I have this full metal jacket, and I can't see anything. And trying to follow them afterwards is like, okay, well, I guess you're okay. If it's hurting, give me a call. But yeah, so.
Yeah, and that's what really drove me into this, was some of the challenges with the plate nail stuff. And I'm trying to marry up too much of the, getting the ATD and all that kind of stuff. But I think that's what, that's what I think is the best way to go about them. And I just would put up the nail, just like, geez, if I could just drill through this now. Like, I mean, if I could, so I try to link them, I try to match up the interlocks or whatever. And so you get kind of some punk interlock, like everything. But right now I've been pretty happy doing that. And I've got another one next week, another, periprosthetic distal femoral non-union. And I saw her in clinic today, and you can get done next week. So that's and I'm going to do the same thing. So that's what I got. I think Amr, you got a bunch of things you want to go through now.
So yeah, this is just my, like I said, limited early experience with it. And then I think one of the last cases, if we get to it, will show what I used to do, and we'll kind of talk about why I've kind of switched over. So this is one of my patients. This is a elderly lady. She was in her 70s that I fixed her inner troch, and she had done reasonably well with that. And then of course comes back and has a fall several months later, and she's got this below. And I've kind of switched over for most of my intertroch fractures of going to the intermediate length nails, just because I like the diaphyseal fit of it, and for me, managing these types of injuries is a little bit easier than a long nail and then having a supracolumnar around that. So anyways, that's why not doing the big long nail, but certainly could be another option. So anyways, yeah, kind of a tough scenario with this, a bit convoluted, not terrible, just not a lot of real estate to put implants. So, at times for these fixation strategies, I've gotten a little bit creative and done a retrograde nail and then a plate around it, and then but I've never really, I don't think I've left the operating room feeling real great about any of my fixation, kind of like what you were highlighting earlier, Dave. Kind of suboptimal nail, suboptimal plate. And so anyways, this is my first foray into IlluminOss. And this was started off with reduction, and then just an early lag screw, and then a medial entry point IlluminOss. And I didn't have my plate on before, but felt pretty good about my reduction, and so then applied the plate afterwards, and anchored it together with that. And I think this was one of my first cases with IlluminOss, and kind of highlighting what you were saying, Dave. The stability part is a little bit, and I've found this for the cases I've done after this. The stability part of it is very rewarding and a little bit scary, in that you can start to rely on it a bit too much. But things start to, I don't know how your experience has been, but for me, after inflating it, even with provisional fixation, it gets very stable. And then it starts to turn almost into like a sawbone. You're like, oh wow, this is really good. And so I'm a little bit afraid of myself of relying on it too much, because it is very, very kind of rewarding.
Yeah, it does feel like once you inflate the balloon, you get that sense like it's kind of stuck, like there.
Yeah. And so, so again, like you highlighted earlier, small percutaneous incision medially, and highlighting the reduction before any definitive implants, and then applying the plate afterwards.
Amr, why'd you do that medial instead of retrograde?
Honestly, this was when I was playing around with it. Like, I was talking to the folks and I was looking at the technique videos for it, and that was the kind of the traditional way for using IlluminOss was a medial entry point. And, for me, it made sense as well to reestablish that medial column of the distal femur. And so that's why I did that. And then afterwards, I have gone more exclusively now to a retrograde starting point for most of these, just because I think it's more traditional. We're all pretty used to retrograde nail start points, and I haven't noticed a big difference as far as stability and alignment and reduction or malreduction in that sense.
That the medial portal and then running it up like that, Jeff Mass would talk about medial end osteoplate substitution, and it sucks not having Jeff around anymore, but he was such a masterful surgeon with the principles of this stuff. And I like this because this is just a different version of medial end osteoplate substitution, the medial column thing, so I've always I like seeing that. Like, I think that's mechanically a great thing to do. And I remember, the principles of fracture surgery book and talking to Jeff about some of this stuff. And I like the mechanical principle of that is actually, it just reminded me of that medial plate and osteo substitution technique
and technically it's a lot easier. Like, I have tried that, and that was
hard.
That was not fun. And and I think I wanted to just quit orthopedics after that. Doing that, I'm like, I don't think I don't ever want to do that ever again in my life. But again, like you said, if you get it, or even with the medial plates, it's amazing the amount of stability we get, right? The femur starts to line up, and it's like, oh, it's not so bad anymore. Whereas relying on our lateral locked implants, and it's the adage of trying to, rather than, if you're trying to touch the tip of your nose, going around the back of your head to do it, rather than just going in direct. Anyways, so this is, again, one of my early experiences. 71-year-old patient that had a total knee several years ago, was working pretty well, and then has this unfortunate metatarsal, a little bit comminuted distal femur, supracondylar shaft fracture combination. And for me, this has become more, these are the cases I would start to look at nail plate combinations acutely. Because I do believe in the single lateral locked implant. I think the non-union rate is not insignificant. I think those numbers that some of the Iowa folks and Paul Turnett has talked about, I think they're real. And so we haven't solved it. And I went through a phase. It's kind of like fashion, like, you start wearing different types of pants or stuff. I started going medial plates, and I thought I was doing pretty good. And then, it wasn't, and so I think we are, we're notorious in orthopedics as far as repeating history, but not remembering history. And I think some of the dual plate stuff, if you can do it, great, but it's hard to do it without stripping a lot of the vascularity of the medial distal femur. And not to mention, it's not entirely safe. And you start getting into some bad things quickly as you start extending them proximally. So anyway, so this one for me, I thought, well, this would be a great indication for IlluminOss. This kind of shows bigger set patient, like I think they're all becoming. So this one, again, I started off with reduction and used a more traditional retrograde nail approach for this. And one of the things that I found, I don't know what your experience with it, Dave, is one of the challenges with nails in these implants, I mean, we're lucky that the newer knee implants will accommodate, even if they're a closed box, they will accommodate an entry portal, but it's very posterior.
Yeah.
And some of the newer nail designs have obviously come out to kind of accommodate that, but my experience with a lot of those is none of them are really great. Like none of them are perfect, and everyone's anatomy is a little bit, even a couple of degrees different. And it can create pretty quickly a sagittal plane deformity.
Yeah.
With your nail, because you're in a suboptimal starting position. One of the nice things I've found with IlluminOss is I don't really care, because it can be right off the posterior cortex, because I can slinky this thing into the trajectory wherever I kind of want it, even if I start incredibly posterior. And it's rigid, but it's also a little bit flexible, that it's not going to be causing that level of a malreduction.
Right.
In the sagittal plane. So again, inflated it after to maintain the reduction, and then applied the lateral locked implant after that.
Awesome.
Again, I remember this case specifically because it was incredibly stable after inflation of the balloon, and then it's just becomes an exercise of putting the plate on in a relatively decent spot to not mess that up. So
yeah,
it's certainly streamlined my approach, and decreased my frustration with some of these challenging periprosthetic distal femur fractures, and even just supracolumnar distal femur fractures in parodic patients.
Yeah.
This is another one that was interesting. 88-year-old, fairly active patient. You can see the clips that, she's not in the best of health from her bypass. And a lot of my colleagues, and I don't know how you've seen this, Dave, but there seems to be a big trend in management of these to acute distal femoral replacement. I mean, just chop it, put it in the bucket, and put a mega prosthesis in.
Yeah. I think that I've kind of noticed that not increasing around, certainly in where I'm practicing now, that I do see some of that happening a little bit more frequently, and I think sometimes it's really the best option for all the points we've discussed. But that's another one that there's kind of no going back from that one either a little bit. So I agree. I don't have the right answer for some of these.
I've seen a pretty dramatic increase in the number of distal femoral replacements in our community, and I think the total joint folks are rightfully that it's the easiest knee to bounce, right? There's no bounce because it's a hinge and it's straight, and once you get over the initial shock of I have 2 feet between bone pieces, looking down at this meat pie, then, and you can fill it with metal, and then they're like, oh, this is super satisfying. And there's a lot of these distal femurs that I think that the pendulum is starting, in our community, I think it's swung to the point where it's a lot of distal femoral replacements. And the salvage for those is, like you mentioned, that there may not be, the salvage may be an amputation. If you have a prosthetic joint infection, if you have maltracking of your patella, if you have another periprosthetic fracture around that, like, you don't really have a lot of room to fix these. So I'm hoping, and I think IlluminOss and some other adjunctive fixation methods can help kind of make that pendulum more in the midline, because my bias is I think we're just doing too many distal femur replacements.
Yeah.
And
It'd be interesting. Like all of this becomes more and more interesting because people are getting younger and younger, getting their first primary,
yeah,
and then uh, you know, I just think that distal femur replacement is great when you're maybe 88 years old or 90 years old or whatever it is, whatever the right answer is. I don't know, but I like, if it's right, then I think that that's the right time to do it. But now if we're having people with 65-year-olds with distal femoral non-unions or smashed supracondylars, I still think we got to fix those people, and I think that
yeah,
that can't be the right bailout. So having as many options to try to fix the problem, I think is good, and I think that's what the IlluminOss for this anyway helps.
yeah. So for this patient again, just highlights pretty comminuted, and you could certainly make the argument, and a very reasonable argument, say, hey, this one might be a distal femoral replacement. I mean,
Yeah,
especially if you lost you lost your medial distal femur, maybe the medial epicondyle. You may not have a lot available in the distal femur for fixation. So anyways, so this one again, more of an indirect reduction with traction on this patient. And, I kind of left the metaphyseal area alone, and retrograde nail approach for the IlluminOss. And yeah, inflated it, and it was relatively stable with that. And then you can see the image on the left with the balloon deflated, and obviously the one on the right with it inflated, and incredibly stable after that, which is again reassuring and also a little enticing, and maybe too much so. And then pretty standard application of a lateral lock plate. And this highlights, this is the one where I started to leave the balloon a little bit more distal, more in the metaphyseal area, not really
yeah,
extended too far up the aphysis.
that's great.
So it takes a